Good morning to everybody. Today we will discuss very important topic, the infertility rising concern and the treatment. We know this is a global problem. Around 17.5 young adult couple are suffering from this problem. And for that they need immediate help for this infertile couple to help them to get their problem solved. So, for fertility we need good egg, good sperm, good embryo, good functioning patent and patent tube, good uterine cavity, good receptive endometrium and timely intercourse. So most of the female and male both are responsible, and in 40% both are responsible. If you see the causes of the blocked tube and septum, adhesion, endometriosis, PCOD, polyp, fibroid, infection, some genetic problem, some hormones problem like thyroid hyperprolactinemia leads to infertility. If you see, out of 6, 1 couple may suffer from the infertility, and around 17.5% adult couple are suffering this infertility, need urgent, affordable, high quality care, those who are in need. As we know, the global fertility rate all over the world is declining. So, youngsters are decreasing, some population is decreasing like in Japan or European country, the total population is decreasing. Why there is infertility? Because of aging effect, because of late marriage, late planning of infertility, because of addiction like smoking, tobacco, drug, pollution, and fast food, obesity, lack of exercise, and infection are the leading cause for the infertility. How will you investigate? Female, we know after clinical examination we have to do some blood test, some hormone test like FSH, LH, AMH, prolactin, and by transvaginal sonography, we can assess the uterus, endometrium, and ovary. What is exact their function? Like if this ovary look like this is a PCOD, so we have to assess the endometrium and uterus on the mid-cycle. So we can assess so many things related to uterus and endometrium, and more advanced technology, the 3D, 4D sonography, we can assess inside the uterine cavity. We can say this is unicornate uterus, bicornate uterus, this is septate uterus, this is bididelphys uterus, this is an intrauterine adhesion. So we can see pathology inside the endometrium and uterus very well by the transvaginal sonography and by the 3D, 4D sonography. We can add this latest technology, Sono AVC. This each and every follicle will calculated by the sonography by doing a volume assessment. So we can say more detail about the follicle function. At the same time, we can do laparoscopy, diagnostic as well as operative laparoscopy to diagnose any problem related to fallopian tube, uterus. If there is fibroid, we can operate it like myomectomy. PCOD, we can delete. If fallopian tube is blocked, we can operate with the laparoscopy. So this is very well advanced. Nowadays, instead of 3D, now 3D and 4K, having more advanced technology, having precise resolution, we can do laparoscopically very well, fertility enhancing surgery. And also there is a robotic surgery also on the way to do more precise surgery on the uterus. So again, hysteroscopy, we have to see inside the uterine cavity. Is there any problem inside like septum or polyp or infection? We can diagnose, we can treat it by the hysteroscopy, which is needed for any fertility treatment. But first and foremost, for the management, counseling is very important. What is the exact problem of the infertility? How will you do treatment? What method you will do? What is the success rate? What is the cost? How many visits will be there? And what is the side effect of the infertility treatment? We have to counsel the patient everything about the success rate and everything. After that, what we will do? Whatever the cause you find, just treat it. go for the modern lifestyle management, about their diet, about their exercise, yoga, meditation, whatever the addiction they have, we can counsel them, stop it, and have a healthy life. Health is wealth. The health will improve, that will improve your egg quality, that will improve your sperm quality, and that will increase your IVF success or infertility success, and baby will be healthy. So counseling of this very important. If you see the simple treatment, then ovulation induction by oral medicine like clomiphene citrate, aromatase inhibitor. When the follicle become mature, you can give trigger like HCG, and you can do plant relation. This is the cheapest treatment, and success is good in indicated cases. If needed, we can add intrauterine insemination. That is a wash semen. We have to prepare in the lab, and we have to put inside the uterine cavity at the time of ovulation. That will increase the chance of pregnancy. Very easy, very safe, cost effective, within the reach of many gynec, and success rate is around 10 to 20%. So you can advise the patient for the at least 3 to 6 cycle of IUI. If it failed, then we have to need IVF. We know first test tube baby of the world, delivered in 1978 in UK, Louis Brown, by Edward and Steptoe, and they won the Nobel Prize. So after that, all the horizon of the infertility treatment, better understanding, better gonadotropin, better sonography, better laboratory, leads to success in lots of IVF result. What are the indication of the infertility or IVF? That is a damage to bilateral salpingectomy, endometriosis, PCOD, IUI fail, male infertility, all azoospermia required infertility. Why there is a more acceptance of IVF? Because of advanced technology, better understanding of physiology, more advance in ultrasound, advance in endoscopy like laparoscopy, hysteroscopy, better gonadotropin like gonadotropin, recombinant gonadotropin, better triggering with analog, and OHSS free clinic. That was the big problem with the OHS before this technology. Again, lab, modern lab is there, triple gas incubator, culture media, that leads to better quality of embryo, like blastocyst. This is the most powerful embryo, and implantation rate is high. And better selection of embryo by doing artificial intelligence. So selection of egg, selection of sperm by artificial intelligence is the case success of the IVF. Now, how will you do more success? Patient selection, ovarian stimulation, expense of the any clinic, and the purity of the drug, and embryo transfer technique, whether you transfer 1 or 2, is very important. So that leads to success in IVF, and because of success and easiness of the IVF, there is more acceptance of the IVF treatment. So what are the protocol? Long protocol, antagonist protocol. In long protocol, many injection, antagonist, very easy, less injection, and we can give analog triggering in case of antagonist protocol. That will save the OHSS, and good result. It will minimize the visit to the hospital. So role is more advanced technology is recombinant technology, easy to deliver. Recombinant, 29 gauge. Patient herself can, or husband can deliver the injection, so they not to go to the daily to the doctor. So that is the advantage of technology, recombinant technology. Gonadotropin is made from the urinary, that is the first generation. If it is purified, that is the second generation, and recombinant is the third generation. What is the advantage of the recombinant? Consistency and increased viability, better quality of egg, no disease transmission, sub-Q pen device is ready to use, PFH injection is available, and chances of pregnancy rate will be high. How will you trigger? Normally, those who have multiple follicle, and if multiple follicle, if you trigger with the HCG, chances of OHSS is high. Now we need safety of the patient. To avoid the OHSS, now we are adding antagonist protocol. When the become mature follicle, we can add analog. And analog will prevent the OHSS, multiple follicle formation. So OHSS free clinic, because it is safety of the woman. So because of this, antagonist protocol trigger the follicle with the analog, freeze all, and you can transfer in the next or next to next months. That will increase the pregnancy rate. So that is the beauty of modern IVF. So so no need of any rest, no work loss, and they can manage the timing of the embryo transfer. So in short, this is a stimulated ovary with the transvaginal sonography, pick up OT, and the embryo is formation, and embryo will transfer in the uterine cavity. This is in short, this is the IVF step. So this is modern IVF lab, all class 10,000 HEPA filter, air handling unit, triple gas, laminar flow, micro manipulator, and laser assisted hatching, embryoscope, vitrification, and strict quality control need for the better culture of the system. So modern lab is there. So again, because of modern lab, so ICSI in a case of intracytoplasmic sperm injection, those who have male factor, less quality of less number of oligoastenospermia or azoospermia need ICSI. So intracytoplasmic sperm injection. In a fertilization failure with the IVF, ejaculatory dysfunction required intracytoplasmic sperm injection. Next. So to have a good incubator, triple gas incubator instead of CO2 incubator. Having better culture system leads to better quality of embryo by the triple gas incubator. Witness system, everybody afraid about there is a mismatch from another couple to one couple. Because to avoid this mismatch, we have witness system to avoid any mismatch. So again, very well advanced technology is there for the better culture system, better embryo formation. Again, how will you improve the pregnancy rate is very important. We need good uterus, good endometrium, good embryo, and for that we have to select the best quality embryo. We have need pre-implantation genetic study. So PGTA, this is a number of chromosome we have to assess. And here PGT-SR, that is structural rearrangement. In case of Robertson's translocation, deletion, inversion, like this we need PGT-SR. Single gene like thalassemia or Duchenne muscular dystrophy, single gene. We have many cases of breast cancer in family, colonic cancer, that we can avoid in a generation by doing PGT-M. We have to select disease-free embryo. There are so many embryo. If we transfer blindly, the transmission chances is there, because thalassemia minor is a major problem. If major is there, then we need to blood transfusion, survival rate is to avoid that type of genetic disease. We can do PGT-M. Cryopreservation, sperm, egg, embryo, we can do cryopreservation. Liquid nitrogen, minus 196 degree temperature, for long time, for future use. So freeze-all cycle is nowadays more comfortable, more giving result, freeze-all cycle. So again, freeze-all oocyte or sperm we can do for long term. Embryo transfer, we have to select the day of embryo transfer. We have to transfer without traumatizing endometrium, 1 or 2 embryo, to avoid twin pregnancy. Again, twin pregnancy have problem with the prematurity and hypertension problem. So better to have a single embryo, but embryo should be best quality, powerful embryo, and the endometrium should be good. Then we can expect good outcome in IVF result. At the same time, we can avoid the twin pregnancy by doing single embryo transfer. That is our motto. We have to give the patient result with the own egg, own sperm, whatever possible. We have to assess the egg function, sperm function, uterine function, and then our target is to give maximum IVF result with the own egg, with the own sperm, by being better stimulation, better handling of egg and sperm, better embryo formation, better PGTA if needed, and transfer single embryo in a uterus to avoid twin pregnancy. If there is thin endometrium, we have to do platelet-rich plasma. So PRP, like a growth factor, we have to put inside the uterine cavity to treat the thin endometrium. At the same time, stem cell from the iliac crest, bone marrow stem cells, then isolate the bone marrow stem cell, then you can inject in the ovary by laparoscopy or by doing catheterization ovarian vessels. So they will go to the ovary, that will rejuvenate the ovary in a case of poor responder. That is the stem cell treatment for the poor ovarian reserve. Again, egg freezing, because of young age, not planning for the pregnancy immediately, career oriented, late marriage, they need egg freezing. That is a social freezing. But in some time malignancy, we need egg freezing. After egg freezing, they can use later on any time in a onco patient, in a special those who are donor recipient program, family history of premature menopause, early menopause, family history. You can do stimulate the ovary, you can retrieve the egg, you can do egg cryopreservation. So that is the way you can do egg preservation. If there is any major problem in egg number or quality, genetic problem, you may need to change it. That is egg donation. Very good result with the egg donation, less visit, and less abortion rate, and success rate will be high in indicated cases. Always we'll try with the own eggs, but if needed, we can do egg donation. Again, if there is a problem with the uterus, then we need surrogacy. Traditional surrogacy, in a surrogate, we have to inject the commissioning couple sperm at the time of like IUI. But here own surrogate egg will fertilize with the commissioning couple sperm. So that is a traditional surrogacy. This is the gestational surrogacy. We have to stimulate the female, take the husband's sperm, make the embryo, you can transfer in a surrogate mother. So this is the gestational surrogacy. As gestational surrogacy, we no need to any pay, that is altruistic surrogacy. Relative or any friend, any volunteer can do altruistic surrogacy. Previously it was commercial surrogacy. We have to pay to surrogate, that is a commercial surrogacy. And now many countries have banned this commercial surrogacy. You can do that altruistic surrogacy. What is the indication? Absent uterus, thin endometrium, hypoplastic uterus, recurrent implantation failure, recurrent pregnancy loss, or mother is not medically fit for the pregnancy, may need surrogacy. So if you see the male, the count sperm analysis we have to do. If it is normal sperm, no problem, but if it is oligoasthenospermia, there is a less motility. Number is less oligoasthenospermia. If more, it is a teratospermia. If everything there oligoasthenospermia, if there is semen, that is a azoospermia. No even semen, then it is a aspermia. So investigate it and treat it. If needed, we can do hormone test, we can do sonography to rule out any varicocele, and then we can treat. So what is the WHO criteria for the normal sperm? This is 15 million sperm is needed, and 4% morphologically normal sperm. That is a recent 2021 WHO criteria for the normal sperm. So male is very important because only female was blamed for the infertility. They will treat the female, do all every treatment to the female, but they, when analysis, male factor may have azoospermia. Then they will realize, now in azoospermia we can give pregnancy with the own sperm. You have to investigate by doing hormone test, by doing scrotal sonography. You can do genetic study, any Y deletion micro, then counsel the patient what are the chances for the own sperm. If testis is normal and FSH is normal, the chances to retrieve, surgical sperm retrieval is good. But if high FSH and small side testis, the chances for the sperm retrieval will be less. So then we can understand this is a PESA sperm. This is a TESA sperm. So this is a TESA, just few parts you have to take and you have to send to laboratory to search any sperm. But we have developed technique micro-TESA. So at the microscope we have to see the incision on the testis, take out the few tubules, and the tubules we have to investigate by the embryologist in the lab, and if we find some sperm we can do ICSI and we can do own sperm embryo formation and pregnancy. What is the advantage of micro-TESA? Is a minimum fibrosis, minimum scarring, fast recovery of the male partner, and more sperm we can retrieve and reduce to damage of the testicular blood flow. So no after procedure, less chance of hematoma, infection, pain to the male partner. But because of azoospermia, we can treat that patient with the own sperm with the micro-TESA. So here you can see the tubules. This is all tubules. This is a normal producing sperm tubules. We can find out under the microscope by micro-TESA. Thank you very much.